Hi, everyone. Welcome to the ATDev Podcast. So happy to be joined today by ATDev friend and collaborator, Dr. Fabrizio Billi, a professor at UCLA School of Medicine. Hey, Fabrizio, how are you today?
Hello, I'm very good. It's good to hear you, Owen. And I want to thank you for the invitation and again acknowledge the work you and the team at Assistive Device Technology are doing. I really admire the focus on building tools that help people regain movement, confidence, and independence in meaningful way. I'm grateful to be here. Really looking forward to the conversation.
Yeah, same here. Yeah, thank you. Thank you again. So, for our listeners, would you mind sharing a little bit about your background and, yeah, what do you do?
My background is in biomechanics and biomaterials originally. Then I translated over the years towards orthopedics, and in particular, then towards developing technology in rehabilitation, in tissue healing, and all the other aspect that pretty much impact our musculoskeletal field. My work in the Department of Orthopedic Surgery specifically sits at the intersection, to find a better word, of how people move, how tissues respond to load or external stimuli, which may include drugs or combination of therapies, and how we design
Yeah,
these technologies, right? Technologies that actually support clinicians and patients across the full continuum of care, but it doesn't just stop when we care, when we deliver healthcare. It goes beyond that, in my vision. So much of what I do has a translational focus. I often discuss these in both scientific journal and through a public facing series called Agentic Orthopedics, where I explore how
yeah,
technology, clinical judgment, human experience intersect. For listeners that who might not know it, agentic orthopedics is really a framework for reflections. Like this core is about preserving and enhancing human agency. It's a term that we often hear these days in the world of AI, and expand this
yeah,
human agency in care. So within that framework, I often describe movement as a contextual vital sign. It tells us not just whether something is wrong, but how a person is adapting to the environment, their demands, and their recovery. That philosophy runs through our research here at UCLA. We study movement and function not only during rehabilitation, but in early detection, maybe when subtle changes appear before they can even be possibly seen on images. In treatment
right.
selection, when context explain why two patients with similar findings need very different care. And then in rehabilitation, as you well know, where load, confidence, and adaptation evolve daily, not just as a routine checkups. In long-term resilience, where recovery doesn't end when formal therapy stops. Clinically, I'm motivated by patients who live in a gray zone where imaging looks acceptable, yet function, confidence, or performance don't feel right. Traditional tools
Yeah.
often struggle there. My goal is to develop conceptual and technological approaches that make those hidden dynamics visible so care can be more precise, humane, and continuous.
Yeah, that's fascinating. And such an important field of study. I think I've obviously had a lot of experience with rehab throughout my life as a wheelchair user and someone who needs physical therapy more from a chronic perspective, from the neuromuscular perspective. And what you're saying, I think, is really interesting about viewing the human organism and the movement really holistically, and about how being able to move or able to recover in a certain way, that's not the that's not the end all be all goal, right? It's
That's
part of a larger view of the human.
Absolutely. That is very correct. And that's why I think context Some people say that I'm obsessed with context, but I think context is very important. One thing is that you examine the patient in the four walls of the clinic or the rehabilitation center. Another is to understand what are the struggles in the daily life, what is the environment the patient moves in, right? And those are lately are slowly creeping into what we define as personalized care and personalized rehabilitation.
Yeah.
So I totally agree with you.
Yeah, yeah, I absolutely. Yeah, so you mentioned personalized care, which is obviously a big buzzword in the healthcare space. I would love to just hear your take and maybe your definition of how you view personalized care from both the perspective of a clinician, but also what does that mean for the patient?
In a broader vision, so far, what we define as personalized care is not really care that adapts to the patient. Mostly what we define is, or we are trying to apply, is protocols to which our patient needs to adapt. And by then, I always reason about what the metrics we are using impact how we treat patients. I'll give you just an example. In rehabilitation after total knee replacement, we often base one of the most used metrics is range of motion. Now, if you
Yeah,
ask any surgeon or anybody in rehabilitation why we are using range of motion as one of the most important metrics, you're going to get very vague answer. And the reason for that is
right.
that the reason for that is that, interesting enough, range of motion was born out of convenience because in the oldest time the patient were observed by the clinician after surgery, and one of the things that in the older days that they were doing, they were looking at how patients were standing up from a chair. And when a patient is sitting on the chair, normally it sits at 90 degrees angle of flexions, and that it's an anecdote, but it's a story on how a metrics was born. So personalization is about definition of different metrics. And when we are going to define these different metrics, the life the patient lives outside the clinic, outside the rehabilitation center, is going to be important to define if a patient is really recovering or is really struggling.
Yeah, yes. Yes, exactly. Yeah, and I think that really ties into a lot of our philosophy. ATDev is that you said it yourself that the in-clinic visits are maybe 0.1% of the patient's life. Most of their life is outside the clinical setting, and it makes sense to be moving these traditionally clinical devices into the home.
Oh, absolutely. Absolutely. Also, because your rehabilitation, as you just said, doesn't stop in the clinic. It doesn't stop when you see your PTs, and it has to continue at home. And right now, what's happening is that we don't have a real sense of what the patient is doing at home, how is guided. Maybe he receives a phone call from now and then to see how he's doing, if there is any issue, any struggle. And the PT itself doesn't get any sense of what's happening outside the rehab, outside that one time clinic visit of the patient to the
Yeah.
rehab. That has to change, right?
Yeah, yeah, absolutely. Yeah, absolutely. I know that you in your research have encountered countless medical devices, some good, some bad, I'm
Right.
sure. I'm curious, when you're evaluating a new technology, what are some of the metrics that you use?
To me, when I evaluate a new technology, it always comes back to three fundamental questions. The first one, does this change a decision If a technology doesn't influence how I progress a patient, modify an intervention, or reconsider a plan, then it may be interesting, but it's not clinically meaningful. Data
Yeah.
is only valuable if it actually shifts judgment at the point of care. The second question is, does the patient feel the difference? Are they moving with more confidence? Are they less hesitant? Are they returning to activity with fewer setbacks? We sometimes get distracted by statistically significant improvement that don't translate into lived experience. For me,
Yeah.
meaningful innovation shows up in how patients behave, not just in how graphs move. And the third, does it survive real world? Does it fit into
Yes.
actual clinical workflow? We have hundreds of technologies that have been developed and they work extremely well in the lab. And then when they hit the clinic, they fail. So and they fail because it doesn't respect time, staffing constraint, cognitive load. A tool that works beautifully in a controlled study but adds friction in daily practice will struggle to scale. What I've learned over time is that novelty is often a mistake for impact. I've written
Yeah.
I've written more than once that innovation without integration is theater. The technologies that truly
Uh,
matters are the ones that quietly reduce uncertainty for the clinician and for the patient without demanding constant attention. Think about it. The most useful technologies that you probably already use are the ones that you don't even think about. So when a
yeah.
technology meets those three criteria, it stops feeling like an add on and starts feeling like a part of care itself. That's when it has a real chance, actually, I would say, a real chance to change the outcomes. I don't know if it's clear.
Yeah, that's amazing. And yeah, so much to unpack there. I love what you say. Innovation without is theater. That's so beautiful. Yeah, and yeah, I would love to. Yeah, I think we're in a time of rapid technological change. AI and robotics are already changing how people, how they work, how they live. What are some of the downstream effects that maybe you're already seeing from AI and robotics, and what are some of the things that you're excited to see in the future, or perhaps maybe not excited to see?
All right. There's a lot of talking these days, and I'm sure you've noticed about physical AI, and that is a specific application of AI, especially to robotics. What's exciting about physical AI isn't really the form factor, it's the behavior. Physical AI allow
Mm,
devices, and it has been developed for robots in particular, to perceive and respond to the physical world we live in, we humans live in. How we move,
right.
how we load our bodies, how we change with fatigue, pain, environment, shifts from static rule based system pretty much to responsive ones, right? So, in practical terms, what that means is that we are moving towards devices that don't just deliver a fixed intervention, but that continuously adjust based on how a person is actually performing. In the home, and that's a very important environment, that opens up intervention that previously required close supervision in a clinic, guided exercise with real time feedback, adaptive resistance or assistance, safer balance and loading tasks, progression that's based on performance rather than a calendar. A philosophy we've
Yeah.
seen reflected in systems like Reflex. As this system evolved, they also opened the door to lightweight forms of digital twins. Not perfect replicas, but living representation of how a person moves and adapts. over time. These representations don't need to be exact to be useful. Their value is in capturing trends and change. So when someone is ready to progress, when they are accumulating fatigue, when there's subtle confidential begin to emerge, the system will face those behaviors. What's important
Yeah.
is that this isn't about replacing clinician, and I always stress this point, or automating judgment. It's
Yes.
about extending clinician intent beyond the walls of the clinic. That is what we are still
Yes.
missing these days.
Yeah.
And this is,
I
go
couldn't
ahead.
agree more.
Yeah, this
Oh
isn't,
yeah.
go
Yeah. It's
ahead,
just so
sorry.
important. Yeah, no, yeah, it's so important what you're saying. These devices, they're tools that will enable clinicians to help more people, right? This isn't about replacing the clinicians because you can't do that, nor should you try. This is about making a better tool. The health
Correct.
outcomes are improved.
That is actually correct. That it's the scope of these tools is actually that. So we are amplifying the capabilities of the clinicians, right? But at the same time, we are also amplify the agency of the patient. A patient will feel more care. We are moving, we can also discuss that we are moving from, we always say that, from a sick care environment to a proper personalized healthcare application, a healthcare model. And that's what really these tools allow us. You were asking how AI will impact you. I'm not too concerned about AI, again, replacing clinicians and replacing other healthcare providers. But I'm much more interested in how we can shape these tools so they are really useful and not just black boxes, right?
Yeah,
There's, if you want to,
absolutely.
there's a psychological dimension that matters also a lot, right? When a patient feels supported, not monitored, but supported, they tend to move to react with more confidence and less fear. Now, that translate has so many benefits. For us, fear of movement is one of the biggest barriers to recovery. Responsive device can help rebuild trust in the body in ways that static instruction simply can't. And for me, the promise of physical AI and AI in general is about making device more complex or more human-like. It's about making care more context aware, adaptive, and
Yeah.
continuous. So high quality support follows patients in the environment where recovery actually happens.
Yeah, yeah, so well said. Dr. Billy, this has been such a pleasure to have this conversation with you. Thank you for your time. And if people are interested in learning more about your work, where can they go to find more information?
They can follow me on LinkedIn. I have also this newsletter I mentioned at the beginning, Agentic Orthopedics, where I discuss a lot of this of these issues, and that's the most updated one. And they can follow my work obviously on the UCLA research page and through my publications in journals. So not only in scientific journals. These are my main interest and my at my heart, discussing how technology is reshaping our world for a better care. I'm an optimistic by nature, so I think we are in the right direction.
Yeah, wonderful. All right, thank you again, Dr. Billy, and thank you to all our listeners. If you found this episode interesting, please don't forget to subscribe and share with someone that may also find it interesting. Yeah, thanks for listening, everybody. Stay tuned for the next one.
Thank you, Owen. Thanks, everybody.